And so at this point, I'd like to introduce my good friend, colleague, and a surgeon who has been with IBD Horizons since day one, back 5 years ago in Seattle. And so he's Dr. Remzi. He's a professor of surgery and the director of the IBD Center at NYU, and we're always so thrilled to have him here. Dr. Remzi?
Thank you so much for having me. And I've been in Ohio since '89 when I first came to the United States fresh off the boat. And the last 4 years, I had the privilege of moving to New York City and being there. And specifically from yesterday's event, as much as this is maybe about the Ohio State, but it's Ohio State's vision. And also, most importantly, Anita, her colleagues and team establishing this really important center that's going to be really valued, collectively working with all of you for the Central Ohio, building a better future and resources for them. And again, congratulations from the bottom of my heart to you and to your colleagues making this happen for Ohio. It means a lot. So I have nothing to disclose as a conflict of interest. I'm going to keep this as simple as possible and open the discussion. When you look at these guidelines, that what we find specifically, I think there's a pretty much good evidence, the colectomy being the right choice for a high-grade dysplasia, and there's insufficient evidence when it comes to the low-grade dysplasia. So what is the surveillance should be when it comes to colonoscopy? I'm the last guy who should be teaching you guys this. This is pretty much your guys' societies, but it's pretty much every 3 years, more frequent if some of the risk factors that PSC, family history, the duration of the disease that plays a role that can be done more frequently. Now, the scenic guidelines came, and I like to remind you it's a guideline. I don't know how these things come up at the background of it. There's not a surgeon, there's not a clear IBD specialist gastroenterologist, and no disrespect to any of these colleagues, but it is a common guideline that is being used right now. And we need to remember it's a guideline. When you look at the guideline, these are the things that they try to answer. How should surveillance colonoscopy for detection of dysplasia be performed? How should dysplasia identified at colonoscopy be managed? And a systemic review was performed for each question to answer these questions. I think one thing that they helped out, some of the terminology, the consistencies that brought a value. They got rid of the DALM definition and everything, and they brought a visible dysplasia, which pretty much 1, 2, 3 different categories, 2 categories to look at it, and then the concept of the invisible dysplasia in the terminology. And this has been the guideline from the scenic guidelines, the management of dysplasia found during surveillance. So after complete removal of endoscopically resectable polypoid dysplastic lesions, surveillance colonoscopy is recommended rather than the colectomy. After complete removal of endoscopically resectable non-polypoid dysplastic lesions, surveillance colonoscopy is suggested rather than the colectomy. For patients with endoscopically invisible dysplasia, referral to an endoscopist with expertise in IBD surveillance using chroma endoscopy with high-definition colonoscopy is suggested. You feel like this is the rule of God written. Here is the evidence. Very low quality evidence, very low quality evidence, very low quality evidence. So we need to be looking at these things carefully, what the guidelines is about. To me, if you ask me one unconditional commitment, endoscopist or IBD specialist, is this type of a problem with the dysplasia and the IBD or UC. And where this is coming from. This is what happens. This is what happens on a patient that Okay? There is that red flag, can you guys see it? That's the area of the rectal cancer that developed on a patient who was under surveillance. So the progression of the cancer and the dysplasia in these settings is not that uncommon. It can happen. What I believe that avoids the progression is the consistency specialized endoscopist doing it, whether it's private or academic. It absolutely drives me nuts. I'm coming from an academic center when people say academics, I mean, it's not the bricks and mortars that make the academic centers, it's the consistency of the endoscopist who knows that colon really well and takes care of the patient's anatomy accountably, that will avoid this progression. That to me is more important because most of the academic centers, the things that may be different, like or schedule with someone else, the 3 to 6 months. It needs to be the same endoscopist that doing it repeatedly on the same patient that knows this anatomy. That was a patient 2 weeks ago that he wanted to avoid a permanent ileostomy, and we gave him a J pouch. He's doing well. PET came back as a SM1T1 with no lymph nodes, and then he's going to have a great life with a good pouch, and he's 65 T now. So this is another patient that came. This would be called a DOM probably in the past, or a polypoid lesion now, what we call that thing. And he had multiple, the sites of a high-grade dysplasia and low-grade dysplasia. I pretty much told him, you need a colectomy, and he went there. He just operated last week, and with a J pouch and a loop ileostomy, and he's going to do fine. Now, the concept of these endoscopically removable dysplastic lesions in every single these guidelines comes pretty much through these studies that pretty high volume, but I like to caution you. It's all about what the guidelines were giving to the whole world. 376 polypoid dysplasia, okay? And the follow-up is around 4.5 years on these patients. Now, there is good news. The chance of this converting to cancer is pretty rare. Can be seen that 9 out of 376 patients converted to cancer, so it's pretty rare. But the conversion to dysplasia is not that rare. It's 100 out of the 376 patients, they develop further dysplasia. And that's the reason consistency, academic, private, consistency, same endoscopist doing the procedures is very, very critical, not to lose the concept and not to lose the map of that individual patient's anatomy. So this is the CINIC guidelines. So bottom line is, dysplasia can complicate colitis secondary to IBD. The relative risk depends upon the duration, extent, severity of disease. Visible lesion arising in diseased bowels should be endoscopically resected. Surveillance colonoscopy is recommended if the lesion is isolated and completely removed. Resection of all at-risk bowel is otherwise recommended. So if something visible, that you take it out, you felt it, you confirmed, and it's one that you moved on. Invisible lesions should be sought by high-quality chromendoscopy. If it's resected, surveillance colonoscopy is recommended if the lesion is isolated and completely removed. Otherwise, resect everything. Now, this part, any invisible lesion except the low-grade dysplasia says that it needs to be resected. To me, it goes both ways, and we're going to talk about it. So what's the message here? Somebody has a multifocal high-grade dysplasia or low-grade dysplasia in my hands, I recommend them surgery. Repeat. Multifocal, high-grade, low-grade, I recommend them surgery, even if it's resected. Unifocal, high-grade, or low-grade dysplasia, like anything else, I think patient needs to be in the middle, but specifically, we need to make an endoscopist and the surgeon multiple decision, the pros and cons of the surgery. So this is the Remzi's rules. Multiple high-grade dysplasia, low-grade ones you see. If it's a well-fit patient for IPA, I go forward with that. If it's a multiple high-grade dysplasia and a low-grade in the Crohn's disease, the rectal sparing, I think IRA can be a good option. I am not a big proponent of a segmental resection in these seconds. There can be very extreme examples, which I'm fine. There is a data from the Scandinavia, from the elderly population, it may be okay. David Rubin just put out an article, very like 17, 20 cases, which is really muddy up with UC and Crohn's, which cannot give a generalized message. So from my part, visible or invisible lesion resected, consider surveillance by the same interested endoscopists. This is the most important thing, I think, for the patient to avoid potential progression, not to miss anything. And if the area is seen concerned, please mark that area with very small tattoo, because trying to tattoo too much, it creates this smorf world that nobody can recognize for later on. So very little tattoo nocaine, rather than too much. Any invisible lesion for me, that after putting the risk-benefit ratio, I do recommend surgery on these patients. Thank you so much again having me here.